Hi, this is Dr. Max Fung, University of California, Davis in Sacramento, California. This session will focus on the histopathologic features of common skin disorders. This is part of our introductory series for resident physicians in dermatology and anatomic pathology that occurs in July and August of each academic year. The session is also appropriate for second-year medical students typically looking for a first introduction to dermatopathology. Each of the disorders listed here will be discussed in turn. The ones listed in yellow are considered cancerous or precancerous entities. And the one exception is we will not be discussing the soft tissue tumors in this introductory session. It's actually coming up, though, as part of our 18-month rotating curriculum in a couple of months. Of course, in order to identify and appreciate histopathologic features, we do need to appreciate normal histology of skin tissue. And so we're going to start by reviewing some of the basic structures in the skin. And as a teacher, I'm particularly appreciative of those who have taught me in the past. And so this is my tribute to Dr. Mark Goldine, a former dermatology attending physician of mine from my training days. He was at the Veterans Affairs Hospital in San Francisco. He's now an expert in teledermatology and also quite artistically talented, both musically and graphically. And so he made this diagram essentially in the pre-digital age, and I'm happy to use it today to teach some of the basic skin anatomy. Starting with the epidermis. To the naked eye, the epidermis is just paper thin, but as we can see here, it actually has a number of cells in it. Here's in the diagram, see if I can make this similar in color, hematoxylin up here. So it has an undulating pattern with a reedy ridge pattern. It's kind of like an egg crate interfacing with the underlying dermis. And so that's that whole area here. So we're going to focus on that in the next few slides. So this is the epidermis, and it contains mostly keratinocytes, but also melanocytes, Langerhans cells, Merkel cells, occasional small trafficking lymphocytes, but we'll focus on the keratinocytes and the melanocytes for now. And we're not actually going to discuss much about the underlying dermis or the subcutis, but we can see that the vascular lymphatic system, hair follicles, sebaceous glands, eccrine, and in some sites, apocrine, sweat glands, and ducts are present, and then an underlying subcutaneous fat layer. And just keep in mind, any one of these cells could undergo a controlled or uncontrolled growth and create a benign or malignant tumor. And then, of course, there's a whole world of inflammatory disorders, which we will touch on only briefly today. So this is a high magnification of the epidermis. So starting with the outermost layer of the skin, the epidermis, it actually makes sense to start with the deepest layer of the outermost layer, if you will, the deepest layer of the epidermis, or the basal layer. Each of the layers or strata have a European name, so stratum basale or stratum basale, depending on how badly one pronounces Italian in this case. But that's the first layer of mostly keratinocytes, cells that are above the dermal epidermal junction, which is an undulating basement membrane zone separating the epidermis from the underlying dermis. The yellow line draws more or less the demarcation between the tops of the basal layer cells and the spinous layer cells above them. We can see there's more or less just one cell below the line with some imperfections here. I can see there might be two cells right there. And then the dotted line here would be the demarcation of the epidermis and dermis, or the DEJ, dermal epidermal junction. And it has an undulating pattern that in 3 dimensions is kind of like the interface of an egg crate. And so we have a reedy ridge in the middle here, and it's surrounded on each side by a dermal papilla, which is an upward protrusion of the upper dermis. In the physiologic state, the normal lifespan of a keratinocyte is more or less about 1 month. And so there's an ongoing process of skin homeostasis that's perpetuated by a subset of the cells in the basal layer. And so we know that a subset of the keratinocytes in the basal layer of the epidermis and in continuity associated hair follicles are considered to be epidermal or epithelial stem cells. And these are the cells that give rise to the subsequent keratinocytes that populate the entire basal layer and also differentiate as we move up into the next layer of the skin, the spinous layer or stratum spinosum. So this layer comprises probably the bulk of the thickness of the nucleated epidermis, and it's so named because of the relatively obvious spines, or these little lines that go in between cells. These are more visible in the spinous layer compared to other layers of the skin where they may not be visible at all. So they kind of look like ladder rungs, or in this case, the bars across an old-fashioned film strip. As keratinocytes continue on their path towards terminal differentiation or cornification into the stratum corneum, the next layer overlying the spinous layer is the granular layer or stratum granulosum, and these granular keratinocytes are characterized by the presence of numerous dark purple or basophilic granules within their cytoplasm known as keratohyalin granules. Notice also how the cells are more flattened out. They lose their kind of more rounded or polygonal contour that we see in the spinous layer. In the granular layer, they're very flattened. And the granular layer is usually just 1 or 2 cells thick in most anatomic sites. And with terminal differentiation, granular keratinocytes form the stratum corneum, which normally has no visible nuclei. We use the term basketweave orthokeratosis to describe the normal appearance of stratum corneum on most anatomic sites, such as the trunk and proximal extremity. And we can see the kind of loose basketweave pattern to the stratum corneum, and ortho refers to normal. This would be in contrast to parakeratosis, which is an abnormal state wherein the keratinocyte nuclei are retained in the stratum corneum, and we'll see several examples of that soon. Truth be told, the daily practice of medicine as a dermatopathologist does not rely critically on knowing all these different anatomic features of the epidermis, but this beginning of the academic year is the perfect time to review them. It perhaps might be the only time that I review them myself. And this year in particular, multiple trainees and even my son who's in high school said, what are the 5 or 6 layers of the epidermis? So we've gone through 4 of them, and here's another one that comes up sometimes and frequently mispronounced by me, but stratum malpighi actually is named after a famous Italian biologist and histologist, Marcello Malpighi, and this term is defined somewhat variably. So I've seen that the stratum malpighi is synonymous with the stratum spinosum in one source. Others include the stratum basale, so kind of the basal layer plus the spinous layer. I use it in kind of perhaps slightly inaccurate but oversimplistic terms to refer to essentially the nucleated epidermis. So a lot of times we'll see changes in the nucleated portion of the epidermis, but the stratum corneum looks normal, or vice versa. The stratum corneum will be abnormal, but the bottom, the nucleated epidermis, is relatively normal. So I just use that stratum malpighi to refer to the nucleated portion, rightly or wrongly. But at a minimum, it's synonymous with the stratum spinosum plus minus the basal layer keratinocytes. It definitely does not include the stratum corneum. I'm going to use this same close-up image of the epidermis several times during this talk, both as a reference for abnormal disorders and now here to compare and contrast with what the epidermis normally looks like on the palm and sole. We often refer to this as palmoplantar skin or acral skin, and we can see right away that there's a significant difference in the appearance of the stratum corneum. So in contrast to the basketweave orthokeratosis of the typical skin on trunk and proximal extremity, acral skin tends to have a very thickened and compact appearance. So you lose those empty white spaces that contribute to the basketweave pattern on other sites. It's just solid. And notice also it's still orthokeratosis because we do not see any retained nuclei. Note also that the granular layer is slightly thickened compared to the typical appearance at other sites. So remember, the granular layer is normally fairly thin, just 1 or a few at most cells, but here we can see that it's relatively thickened, 3 or 4 cells or more in this acral site, and this is termed hypergranulosis. We can also see the reedy ridge pattern in the epidermis. Note that in some areas the reedy ridges can be bridged or fused together. That, to an extent, can be a normal variant, but it also can be accentuated if the tissue sections are not perfectly perpendicular to the epidermal surface. It can also be accentuated in certain disease states such as psoriasis. Here's an area where an eccrine sweat duct is connected to the epidermis. This connects through to the surface where the sweat is excreted in an area known as the acrosyringium. And on acral skin, it has another name as well, the crista intermedia or crista profunda intermedia. We also have some blood vessels in the dermis, collagen fibers, these pink fibers, and empty white spaces in between that presumably represent some interstitial fluid and a little bit of mucopolysaccharide or mucin, as well as sparse spindle cells that represent a combination of fibrocytes and dermal dendritic cells for the most part. Last but not least, but sometimes forgotten by me, there's one last stratum or layer in the skin, and it's generally only seen on acral skin. This is the stratum lucidum. This is a relatively pale or clear or lucid layer between the stratum corneum and stratum granulosum. Although I've never used the stratum lucidum to make a diagnosis of a skin disease, it does have an important physiologic function. It's a relatively soft, flexible, or stretchy layer that helps to confer some protection against the shearing forces from the outside world, particularly prominent on the palm and sole. So it's relatively soft compared to the hard overlying stratum corneum. And that's been attributed to a more oil-rich content, as well as a unique protein known as eliodin, which is derived from keratohyalin granules and eventually keratinizes to form the overlying stratum corneum. Although the majority of the cells in the epidermis are keratinocytes, in the normal state there are a population of melanocytes. They're typically single cells within the basal layer of the epidermis, evenly spaced between keratinocytes, approximately one melanocyte for every 7 to 10 or so basal layer keratinocytes. And they can usually be distinguished on H&E stains. So keratinocytes sometimes have a perinuclear retraction artifact as shown here, and that's very distinctive for keratinocytes. In contrast, melanocytes, as shown here in the basal layer, sometimes but not always will have a retraction artifact around the cell, but when they do have a retraction artifact or clearing, typically it's around the entire cell. So we see cytoplasm surrounding the nucleus and then a peripheral cleft, whereas with the keratinocyte, we see a cleft around the nucleus of the cell and then cytoplasm beyond that. The other major histologic clue for identifying keratinocytes is the presence of the intercellular spines, most prominent in the spinous layer. These are those little lines between cells that represent intercellular junctions that hold the keratinocytes together. They look like ladder rungs or the lines on the film strip that I showed you before. Each one of these lines or rungs is actually a pretty complex structure known as a desmosome. And the desmosomes, as you can see here, spans the cell membrane of adjacent keratinocytes and is connected to internal cables or intermediate keratin filaments that are characteristic of the keratinocytes. At the dermal-epidermal junction, there's an analogous structure known as the hemidesmosome, and this would be present here. Typically, we can't see that on H&E. The strength and barrier function achieved by keratinocytes and their associated desmosomes has been compared to that of the much more rigid and inflexible brick wall, with the keratinocytes analogous to the bricks and the desmosomes the mortar. Depending on the style of the brick wall, it actually matches up somewhat nicely. And if you think that I too can be influenced by recent experience, you'd be right. I don't have any disclosures for this talk, by the way, unfortunately. And now, armed with our knowledge of the appearance of normal skin, with particular attention to the keratinocytes and melanocytes in the epidermis, we can take a look at some of the common tumors. The seborrheic keratosis is among the very most common. It's a benign epidermal neoplasm with distinctive clinical features. They're incredibly common, so the vast majority are not biopsied, yet the seborrheic keratosis still represents one of the most common lesions that actually do undergo biopsy. And the reasons are, well, there's multiple, but first of all, they become more common with age, and so true for skin cancers. Secondly, there's a wide variation in their size and appearance, including a wide variation in pigment, such that there is a frequent overlap with the appearances of melanoma or other skin cancers. Microscopically, a histologic hallmark of the SK is acanthosis, which is a thickening of the epidermis. And specifically, it refers to thickening of the spinous layer. So once again, from a practical point of view, kind of like the situation with the stratum malpighi, I essentially think of acanthosis as a thickening of the epidermis minus the stratum corneum. Papillomatosis is also a characteristic feature, characterized by a undulated or bumpy surface to the lesion. And in seborrheic keratoses, the papillations are more often flat-topped rather than pointed. I believe it's been over half a century since a TV sitcom from the 60s called The Munsters ran. Even I'm too young to remember this one, but one of my attendings was not, and so he called the flat-topped papillations the Herman Munster sign. Frankenstein, or Son of Frankenstein sign, is a little closer to my own personal experience and that of my boys. Although warts, such as the common wart Verruca vulgaris, are very common, we're not covering them in this session because they're actually not that commonly biopsied. It's usually a clinical diagnosis. However, when they are biopsied, they can exhibit significant overlap with seborrheic keratosis. And in fact, there's a variant of seborrheic keratosis that we report routinely as verrucous or digitate seborrheic keratosis, reflecting those overlapping features. One of the key differences between a verruca and a classic SK with flat-topped papillations is the shape of the papillations. So compared to the flat-topped papillations in seborrheic keratosis, in verruca vulgaris, they're more pointed, perhaps like a church steeple, or the cone heads. The follicular plugs that are often seen clinically in seborrheic keratosis are reflected histologically by the presence of horn pseudocysts, sometimes referred to synonymously as pseudohorn cysts. These are superficial dilations and pluggings of hair follicles within the seborrheic keratosis. And any one of these, if they get followed up to the surface, they open up into the surface, hence the name pseudohorn cysts. So you can see the connections to the surface. So an individual cross-section looks like it's a cyst, but if we get the right section, we can see that these all connect to the surface, and in fact, they're dilated hair follicles. At the base of the seborrheic keratosis, rather than a preserved reedy ridge pattern, we'll typically see more of a thickening and kind of a flat bottom profile to the seborrheic keratosis. And in looking at the thickness or the acanthosis that makes up this SK, compare here on the right that same reference of normal skin, drawn somewhat to scale, but actually still larger than the actual panoramic view of the adjacent seborrheic keratosis. We can see how much thicker in the keratosis is the epidermis, and that's the, again, acanthosis. That's a hallmark of seborrheic keratosis and other keratoses. Here's a summary of the seborrheic keratosis. And how about this one? More experienced residents. If you want to test yourself, pause and diagnose. This is actinic keratosis, also known as solar keratosis. Actinic keratosis, or AK, is another very common form of keratosis that's considered to be a precancerous lesion. It generally arises on chronically sun-exposed skin of fair-complected adults, and in a small percentage of cases, it can transform into invasive squamous cell carcinoma, or SCC. The lesion is characterized by atypia of the epidermis, primarily of the basal layer, and more generally the basilar epidermis. So the lesion here is demarcated more or less by the yellow line. So if we look to the right of the line, we can see relatively normal keratinocytes with relatively small, uniformly round nuclei and relatively abundant cytoplasm. And within the keratosis, we can see some atypical nuclei, large, hyperchromatic, crowded, and mostly in the lower portion of the epidermis. At the top of the lesion, we have an abnormal stratum corneum. This is parakeratosis, characterized by retention of the keratinocyte nuclei. Remember, in ortho or normal keratinization, the nuclei are lost. Here they are retained. Another view of actinic keratosis. Parakeratosis in the stratum corneum, and one can more or less draw a line somewhere through the middle of the epidermis, and the vast majority of the atypia should be below the line. As with the seborrheic keratosis, actinic keratosis is also very common and very distinctive clinically. The vast majority of cases are not biopsied, they're diagnosed clinically and treated, and it's typically when a lesion is refractory that one then thinks about possibly doing a biopsy to rule out early squamous cell carcinoma. The AKs tend to have a distinctive kind of rough, scaly appearance. Not uncommonly, AK is a split-second diagnosis at low power without having to go to high magnification. Distinctive features include the presence of severe solar elastosis, which is abnormal elastic fibers that accumulate in the upper dermis, displacing the pink collagen. Also, the phenomenon of adnexal sparing. So the actinic keratosis generally involves the epidermis. As shown here, we can see the parakeratosis. But at least in the early stage of AK, there's relatively spared adnexal epithelium. So here's a hair follicle, and we can see that we don't have the crowding of the basilar epidermis, and we have basketweave orthokeratosis associated with this hair follicle. This is another area that probably is an edge section through adnexal epithelium because it has orthokeratosis. Then we're back to AK. Here's another hair follicle that's relatively spared, another hair follicle that's relatively spared, and so on. So this alternating orthopara pattern is quite distinctive at panoramic view. And even at higher magnification, the overall pattern can be more distinctive than the actual cytologic features. So here we have the parakeratosis and just a slight atypia and crowding of mostly basilar keratinocytes below. There's just a slight enlargement of the nuclei, slight tinctorial change with slightly more pale cells compared to the spared hair follicle. And you have, again, normal reference on the bottom left image inset. And then, again, a little bit of actinic keratosis here, sparing of an adnexal structure, and then it picks up again off to the right edge. Again, sparing of follicular epithelium in AK. Compared to SK and AK, the clinical appearances of squamous cell carcinoma in situ or Bowen's disease is probably less consistently clinically classic. And so although these lesions are somewhat less common than AK and SK, there's probably a much higher proportion of them that do get biopsied. Typically, they'll present as a flat, often erythematous patch or hyperkeratotic plaque, and the clinical differential is often with superficial basal cell carcinoma, which we'll look at soon and would be a separate independent indication for biopsy, but also sometimes dermatitis. So nummular dermatitis, for example, can sometimes look like Bowen's disease. Microscopically, there are distinct features. The reedy ridges tend to be somewhat bulbous or fat, and just think about that full thickness atypia with atypical keratinocytes proliferating and filling and expanding the epidermis. Typically, there will be kind of more randomly scattered or full thickness atypia rather than the basilar atypia of actinic keratosis. Typically, there will be increased mitoses and dyskeratotic or abnormally prematurely cornifying or attempting to cornify. And then oftentimes the tumor cells will have an abundant pale or clear cytoplasm. The term pagetoid cytology is used for that. And then often we see the opposite pattern than we do with actinic keratosis, with relative sparing of the basal layer in Bowen's disease compared to actinic keratosis, AK, wherein the atypia is generally greatest in the basal layer or in the basilar epidermis. At the panoramic view, we can see an example of Bowen's disease, and we can see that overall the reedy ridges are just a little bit wider and more bulbous compared to the normal skin. Dr. Goldein's diagram shown here. And in the lower left image, we can see an example of the eyeliner sign, wherein the basal layer cells are relatively small, relatively orderly, and relatively spared relative to the atypia of the keratinocytes above them. Other terms for the eyeliner sign include the skyline sign or crushed basal layer. But they're all describing the same thing, a relatively discrete and non-atypical basal layer of keratinocytes with full thickness atypia overlying. So one of the pitfalls sometimes is that sometimes the normal basal layer of the epidermis looks like somewhat of an eyeliner, especially if you're looking for it. But this sign does not apply unless there's atypia overlying the basal layer. And the way that I think of it, the way that it makes sense to me based on histomorphology, is that I think about squamous cell carcinoma in situ, or Bowen's disease, as a neoplastic transformation of a spinous layer, keratinocyte, whereas in contrast, I think about actinic keratosis as a neoplastic transformation of a basal layer keratinocyte. And when I think of it that way, the way that it appears in the tissue sections makes sense to me. Admittedly, however, I do not have any supporting scientific citations I can offer to support that. All I can say is that it's gotten me through practice thus far. Here's a different example of Bowen's disease, showing again the bulbous reedy ridges, but also a good example of that pagetoid cytology, the pagetoid keratinocytes that represent the lesional abnormal keratinocytes in Bowen's disease. So the cytoplasm is relatively abundant and pale, and you can see that there are some skip areas where there's some sparing of the basal layer in some areas, so that's a little focal eyeliner sign that's a clue to Bowen's disease. But then if we look up top, we do not have full thickness atypia, and we can even draw a line in the mid portion of the epidermis in some areas of the lesion, resembling the line that you can draw consistently in actinic keratosis. Yet there are multiple foci in this lesion, in this view of the lesion, where there's full thickness atypia. Moreover, there are skip areas, not only from side to side, but also from top to bottom. So in the not quite complete confluent expression of Bowen's disease, there can be skip areas like this, not uncommonly. And so we can't just go reflexively by is it full thickness or not. That's part of it, but it also depends on the pattern of the atypia in addition to cytologic features when you have them. Moving on, more experienced observers may choose to pause here and diagnose. This is SCC, squamous cell carcinoma, and when we use the term SCC, at least in dermatopathology, we mean invasive carcinoma. So the non-invasive variants are termed Bowen's disease, or AK, as we just discussed, but SCC means invasive cancer, invasive carcinoma. And so here we see in this central portion, in addition to the tumor, which is characterized by irregular aggregates of more or less eosinophilic or pink epithelium with the same cytologic atypia that we saw either in Bowen's disease or actinic keratosis. In addition, we have a central ulceration and background epidermis off to the side. We also do have parakeratosis here, which we talked about having a distinctive pattern in actinic keratosis. Didn't really say much about it in Bowen's disease. It's a variable feature in Bowen's disease, but sometimes, as in the previous image, if you want to go back, sometimes the absence of parakeratosis in the presence of significant atypia can actually be an indirect clue to Bowen's disease as well. Squamous cell carcinoma is much more likely to be clinically and histologically ulcerated. The tumor cells are squamoid, meaning that they have more or less eosinophilic or pink cytoplasm, more or less the same color as the surrounding epidermis. And I'm using pink here. This will become more apparent when we contrast the more purple appearance of basal cell carcinoma. The growth pattern in squamous cell carcinoma is variable. It could be nodular or more infiltrative. A characteristic clue is the presence of focal keratinization or cornification, basically attempts to form stratum corneum within the tumor aggregates, and sometimes they're very small. They're referred to as keratin pearls. We can usually see one or more parakeratotic nuclei within those keratin pearls that are associated with squamous cell carcinoma. And if our differential diagnosis is carcinoma versus non-squamous cell carcinoma, finding those desmosomes, those intercellular junctions or bridges between tumor cells, can also be very helpful. Here is another example of squamous cell carcinoma at higher magnification. We can see that there are irregular aggregates of atypical keratinocytes with variably nodular and more infiltrative aggregates compared with the normal reference on the upper right. There's another keratin pearl. And background epidermis highlighted off to the left of the image. And notice that the tumor is more or less the same color as the background epidermis, more or less pink. In some areas of this SCC, the tumor cells do appear a little bit more pale, but the most pale areas are actually collagenous or myxoid edematous stroma in between tumor aggregates. So this is stroma here. Here's tumor. Now this is stroma here. Here's a keratin pearl. Not the best formed one, but happens to be right there. In the world of dermatopathology, Gothic flying buttresses are most characteristic of keratoacanthoma. And here we see both a characteristic clinical image as well as a panoramic view of a excised lesion. Characteristic features include these overhanging epidermal papillations likened to the flying buttresses. Typically, the tumors have abundant pale or glassy eosinophilic cytoplasm and central keratotic follicular plugging. Keratoacanthoma is somewhat of a controversial entity within dermatology and pathology. Some authorities classify it as a distinctive variant of squamous cell carcinoma, whereas others hold it to be separate. And most textbooks will have keratoacanthoma as a separate section from squamous cell carcinoma. Yet the histologic and sometimes clinical overlap can be quite profound. So in our institution, we do it like many others do, but not all institutions. We generally report these as squamous cell carcinoma keratoacanthoma type. However, what's not controversial about this entity is that there are distinctive clinical and histologic features. And so as a pathologist looking at the slide, especially if it's a partial sampling, it may be difficult or impossible to tell whether it's a keratoacanthoma or not. And so from a practical point of view, it makes sense, especially off partial samplings. The other factor is that the diagnosis is somewhat of a clinical pathologic correlation, which is somewhat unique in the world of skin cancers. But we do expect in a keratoacanthoma to have a somewhat classic history of a relatively rapidly growing nodule with that central keratotic core evident clinically. And if left untreated, these tumors undergo spontaneous regression as a rule. Now, we know that any one tumor can break the rules or not read the textbook, but this is the standard teaching, and this would be one of the major arguments in favor of not calling these squamous cell carcinomas. Histologically, the features are distinctive, as I showed briefly. The buttresses, the large glassy pale eosinophilic keratinocytes. There often are little collections of neutrophils within the epithelial component of the tumor. And at the advancing edge, at the periphery or the basal layer of the tumor, we see varying degrees of atypia, ranging from the subtle to the severe. Here at medium magnification, there is a view of the mid portion of the tumor. We can see a thickened epithelium composed of keratinocytes with abundant pale eosinophilic cytoplasm. If we look in the central portion of the tumor, we can appreciate that there really is no atypia to speak of here. Nuclei are small, uniform, and round. Cytoplasm is abundant, so the nuclear to cytoplasmic ratio is very low. We do have some collections of neutrophils here, which are characteristic of keratoacanthoma. However, if we looked at the advancing edge of the tumor, areas like this, then we will see atypia that basically is in a high-powered vacuum indistinguishable from that of the edge of an actinic keratosis or any other squamous cell carcinoma. So at high magnification, we can see that at the advancing edge, this could be a close-up view of a thick actinic keratosis or the advancing edge of any other squamous cell carcinoma. Note that we do know that it is an epidermal tumor, though. You can see those intercellular bridges in various portions of the tumor. And rounding out the common forms of carcinoma of the skin, we have the most common cancer in Homo sapiens, bar none, basal cell carcinoma. A variety of growth patterns, most common being superficial or nodular. Sometimes we'll see micronodular or infiltrative growth patterns, which are a little bit more aggressive, although the vast majority of these tumors are cured with local therapy. The superficial variant of basal cell carcinoma is the one that looks clinically sometimes like Bowen's disease, squamous cell carcinoma in situ, a flat erythematous patch. Nodular basal cell is that classic pearly telangiectatic papule or nodule, often with a kind of a waxy appearance. In this particular image that I'm showing, notice that the center of the tumor is also ulcerated or eroded, and so I suspect there might also be an infiltrative component here. Infiltrative BCC doesn't always have as distinctive of a clinical appearance compared to superficial and nodular BCC. It often is kind of insidious. It's difficult to judge exactly how much undermining or deep extension of an infiltrative basal cell carcinoma might be present from the clinical appearances alone. Histologic hallmarks of all subtypes of basal cell carcinoma include peripheral palisading of the tumor and clefting between the tumor and adjacent stroma, typically with a myxoid mucinous appearance. And in contrast to squamous cell carcinoma, where the tumor cell cytoplasm is more or less eosinophilic or pink, the tumor cells in BCC have relatively scant cytoplasm so that the basophilia of the nucleus predominates, and the overall appearance of the tumor even from low magnification is that of more of a purple or basaloid tumor. One more comment about the subtyping of basal cell carcinoma. It is something that we as pathologists should attempt to do in every instance. It may not be possible in every case, and in that case it would be appropriate to say that the sample doesn't permit subtyping. Multiple studies have also shown that subtyping basal cells off shave and punch biopsies is not super accurate, maybe 80%, so not bad, but definitely far from perfect. But the reason that we strive to do the subtyping is that the subtypes, depending on the exact situation, can determine the range of treatment options that are available for the patient. The vast majority of basal cell carcinomas can be readily, quickly, and accurately diagnosed, even from scanning magnification alone. In this example of superficial BCC, we can see the purple aggregates kind of in a multifocal pattern that represent the tumor, as shown here. Even from low magnification, we can see that there's a little bit of clefting or separation between one area of the tumor and the adjacent stroma. Here's that clefting or retraction at higher magnification. And to the left of that, we can also see an area of peripheral palisading. And this is indicated by the outermost layer of tumor cells being somewhat relatively organized in their orientation. So it's somewhat similar to the eyeliner sign, except that the cells aren't particularly crushed or spared. As you might expect, nodular basal cell carcinoma is composed of more or less nodular aggregates of tumor cells. And again, it's diagnostic from scanning magnification alone We see more or less rounded aggregates of purple or basaloid tumor cells. Many of these tumor aggregates don't have clefts around them, but usually if you have enough of a sample, there will be a giveaway somewhere. So there's a little bit of cleft right here, and then, wow, massive cleft. The giveaway cleft, if you will. Here's a closer view. And even closer. The myxoid stroma associated with basal cell carcinoma characteristically collects within the cleft, within that area of retraction. In this image, I think the mucin is most prominent in the area surrounded by the black dots, but the areas highlighted in yellow additionally show lesser amounts of mucin in the same characteristic locations within those clefts. So often the more you look, the more you find. Let's get those funny yellow marks out of the way now. As the name implies, infiltrative BCC is characterized by infiltrative or narrow, jagged, or spiky tumor aggregates. And sometimes the peripheral palisading and the clefting, the mucin, may not be quite as prominent as in the other subtypes. But when that happens, just take a step back and say, is this tumor purple or is it pink? If it's purple, it's probably BCC. Turning our attention now to the melanocytes, the benign neoplasm of melanocytes is known as the melanocytic nevus, or the lay term mole. And we're looking here at scanning magnification just for reference. This is using a 2x objective on the microscope, and when combined with the eyepiece, that's 20 times magnification. Compared to basal cell carcinomas, it can be more difficult to make a diagnosis of a melanocytic nevus from scanning magnification, although we often can. Circled here in the green is a compound melanocytic nevus. The clinical lesion is depicted here as well. This is an exact clinical pathologic correlation. We can see that it looks just a little bit busy. It's a little bit cellular in this area, both along the junction and in the upper dermis. Now we can more easily see these nests of melanocytes. In this particular case, they have brown pigment in their cytoplasm. That's the melanin pigment that they synthesize. Once again, the more you look, the more you find. So there are many nests of melanocytes here. And in addition to their pigment, because they're not always pigmented, we also see that there's a little bit more clearing or retraction around the nests of melanocytes. And so this is basically can be viewed as an exaggeration of the same clefting and retraction that can be seen around and facilitates identification of single physiologic melanocytes in normal epidermis. Our working definition of melanocytic nests is usually 3 or more cells. Once the melanocytes form a nevus, we can also call them nevus cells or neomelanocytes if we like, but they're basically benign melanocytes. And we can see some of these nests here. Some of them appear to be attached to the epidermis. These would be junctional melanocytes. As we go deeper, some of these may or may not be attached, and eventually in a compound or intradermal nevus, it's clear from the appearances that the melanocytes are in the dermis rather than attached to the epidermis. Although the melanocytes are the melanin pigment synthesizing cells, the melanocytes themselves may or may not contain visible melanin pigment. In this particular example we're looking at, they do, so that's kind of nice. But in many other examples, the melanocytes will not show obvious pigment, and one must rely even more heavily on that clearing and retraction artifact that's characteristic of melanocytes irrespective of the pigment status. In some cases, the keratinocytes adjacent will have more melanin. In addition, in the upper dermis, sometimes the melanin drops out, so-called pigment incontinence drops out in the upper dermis, and it's taken up and collected by macrophages forming melanophages. And so these very heavily pigmented cells that are more scattered rather than nested in the upper dermis are consistent with melanophages, not melanocytes. These clinical images all depict intradermal melanocytic nevi, often removed for cosmetic reasons, often with annoying hairs sticking out of them, as we can see in this shave biopsy, which shows the upper portion of an intradermal nevus with nests of melanocytes not clearly connected to the epidermal surface. At higher magnification, we see nests of melanocytes in the mid-dermis. It's the nested pattern of growth that identifies this as a nevus, because note there's no overt melanin pigment, and this would be typical for an intradermal melanocytic nevus. So nevi can be divided into three categories based on the areas that are involved. I showed you first a compound melanocytic nevus, which has both nests attached or within the dermal epidermal junction within the basal layer, but also involving the dermis. I then showed you an example of the upper portion of an intradermal melanocytic nevus where the melanocytes are only in the dermis. And what we're skipping over, because it's kind of a component of the compound nevus, is the junctional melanocytic nevus, where we have nests of melanocytes only in the basal layer of the epidermis. And as you might imagine, the junctional nevi clinically are macules, whereas compound and intradermal nevi are papular or elevated lesions, somewhat generally proportional to the extent of the dermal component. General rules for melanocytic nevi are that they have a symmetric profile. Most of them tend to be small, although we know that there are medium and large giant congenital nevi. And overall, for melanocytic nevus, in contrast to melanoma, we like to see well-circumscribed tumors. And microscopically, that usually means that at the periphery of the tumor, in the junctional component, it ends in a nest rather than single melanocytes. Another hallmark of a melanocytic nevus is maturation with descent into the dermis. So circumscription applies to the junctional component of a nevus. Maturation applies to the dermal component of a nevus. And in maturation, the nests and also the melanocytes within the nests both get smaller. The nests often break up into single file strands towards the deeper portion of the lesion. Another concept that goes hand in hand with maturation is zonation. And the concept here is that if one draws a parallel line kind of horizontally slicing the dermal component of the nevus, within each zone, the growth pattern and the cytology should look more or less the same. So that in the top zone, above the green dotted line, the nests are larger, and in the bottom zone, below the purple dotted line, the nests are very small. Sometimes they're broken up into single strands. And then in the middle zone, between the green and the purple, the nests are intermediate in size between the zones above and below. And in the deep portion of this intradermal nevus, we see the growth pattern as single file strands. The melanocytes themselves are also getting smaller. Sometimes it can be difficult to distinguish them from small lymphocytes. The single file growth is associated with congenital melanocytic nevi. The malignant counterpart of the melanocytic nevus is melanoma, also known as malignant melanoma, although it's somewhat of a redundancy since all melanomas are malignant. There are no benign melanomas. Likewise, all melanocytic nevi are benign. There are no malignant. Somewhat analogous to carcinoma in situ, the earliest stage that we call melanoma is melanoma in situ, in which the tumor is confined to the epidermis and sometimes associated follicular or sweat ductal epithelium without invasion into the dermis. Typically presents as an irregularly pigmented, sometimes quite large, macule or patch. In melanoma in situ, there is an increased number of mostly single melanocytes, not only along the basal layer, but also in the mid and upper portions of the epidermis. And here's where our knowledge of normal histology comes in handy. We can see a lot of clefting or retraction around many of these cells. Those are the tumor cells. At higher magnification, we can see markedly increased numbers of melanocytes that are cytologically atypical. These yellow arrows are pointing to a number of the cells that are present above the basal layer. We can see that most of them have clearing or retraction around the entire cell, not just the nucleus of the cell. And we can see that many of the cells are cytologically atypical. Here's one particularly large hyperchromatic nucleus. There's also some spindle profiles which are very atypical, and pretty much all of these cells have that clearing around the entire cell. Just in the way that we assume squamous cell carcinoma is invasive unless otherwise specified, the term melanoma connotes an invasive lesion unless otherwise specified. The tumor thickness is arguably the single most important prognostic parameter that can be reported from a new primary cutaneous melanoma. It's typically measured from the granular layer to the base of the tumor, and in this particular example, the tumor thickness is 1.2 millimeters. At higher magnification, we can see the upper portion of this invasive melanoma with normal skin for reference on the upper left-hand corner. The vast majority of melanoma invasive will show changes of melanoma in situ in the overlying dermis. So again, we can see pagetoid upward scatter of atypical melanocytes as well as an unusually large nest composed of cytologically identical atypical melanocytes. Looking at the underlying dermis, we can see irregular nests of atypical melanocytes. There's no apparent maturation or diminishment in nest size or melanocyte size with descent into the deep dermis. In this particular nest, there is a mitotic figure visible. Also note the relatively dense lymphocytic host response surrounding the tumor. Lymphocytes, mitosis, which we'll look at closer. So in addition to tumor thickness, the mitotic rate or mitotic index of dermal melanocytic tumor cells is an important prognostic factor. And in fact, there's actually a short or not so short list of histologic prognostic factors that are routinely reported for melanoma. This is required for laboratory accreditation, and the format of the report should be a synoptic report. So rather than a long paragraph where critical information is buried within a long paragraph, this is a bullet point list, stereotypically in the same order for every report, that shows the key features. So we talked about tumor thickness and mitotic rate. The ulceration status is also very important, and other things that may be somewhat intuitive, such as lymphovascular invasion, microsatellite metastases. Now we also try to identify the melanoma subtype as well, because that can have various implications that we're not going to go into today. Turning our attention now to inflammatory skin diseases, we can see that there's nearly a dozen patterns of inflammation recognized in the skin that form the basis for microscopic interpretation. For today, we're just going to go over perhaps the prototypical example of the first three patterns. The rest of our 18-month curriculum includes 2-hour teaching sessions on each of these topics. When dermatologists and other clinicians say, oh, the patient has a dermatitis, more often than not, they're referring to what on biopsy would be reported as a spongiotic dermatitis. So spongiosis is the hallmark of these entities. We'll take a look at that, but this corresponds to all the different forms of dermatitis and eczema, such as atopic dermatitis, which many people just call eczema, also nummular dermatitis, dyshidrosis on the palms or soles, and allergic or irritant contact dermatitis. All of these various forms of dermatitis are associated with spongiosis, which is defined as epidermal intercellular edema. We see widened spaces between keratinocytes, making those desmosomes more prominent. With sufficient spongiosis, spongiotic vesicles form, small collections of intercellular fluid associated with various inflammatory cells, such as lymphocytes, sometimes eosinophils or neutrophils, as well as resident intraepidermal Langerhans cells. The prototype for psoriasiform dermatitis, not surprisingly, is psoriasis. And most of us are most familiar with plaque-type psoriasis, or psoriasis vulgaris, which is quite distinctive clinically. In the vast majority of instances, biopsy is not required. However, histopathologic features are quite characteristic. The psoriasiform epidermal hyperplasia is characterized by an elongation of the reedy ridge pattern. typically parakeratosis with neutrophils is also present. This is a better than average example of the regular psoriasiform hyperplasia seen in psoriasis vulgaris. Note the elongated reedy ridges. They're slender, elongated. Some of them are a little bit club-shaped or fused together, and we can pretty readily just kind of draw a straight line underneath them, and they're all about the same length. Other characteristic features include thinning of suprapapillary plates. So now we're looking at the dermal papillae extending up here, and relative to the elongation of the reedy ridge, this distance between the tip, the papillary dermal tip, and the start of the stratum corneum, which is completely parakeratotic here, this distance is diminished. So this is what is meant by thinning of suprapapillary plates, another feature of psoriasis. In addition, the blood vessels within these papillary dermal tips are often somewhat dilated, and they often just touch right beneath that dermal-epidermal junction. The parakeratosis with neutrophils, that's quite typical of psoriasis. In and of itself is not that specific. It can be seen in spongiotic dermatitis, but the pattern of the neutrophils in psoriasis is often somewhat more distinctive. The neutrophils form collections, and they often have this kind of layered appearance within the epidermis. So we see the neutrophils here. These are tiny little dark dots, and they often kind of have this sandwiched or layered appearance within the parakeratosis. At some point, I was told that collections of neutrophils often resemble collections of ants, crushed ants. One of the prototypes for interface dermatitis is lichen planus. Interface dermatitis refers to inflammation obscuring the interface of the epidermis and dermis, so inflammation centered upon that dermal-epidermal junction. Specifically in lichen planus, there's epidermal alterations characterized by jagged or sawtooth-shaped reedy ridges and single apoptotic or necrotic keratinocytes. These dying keratinocytes have condensed eosinophilic cytoplasm, and you may or may not see a pycnotic basophilic nucleus, depending on the plane of section and sampling. Interface dermatitis can be stratified into sparse or vacuolar interface reactions and densely inflammatory or lichenoid reactions. And not surprisingly, the prototype for lichenoid interface dermatitis specifically is, again, lichen planus, as shown here. We see a number of epidermal changes that we saw before. We have a thickened, compact stratum corneum, even though the biopsy is not from the palm or sole. There are areas with hypergranulosis, often in a wedge-shaped profile, and then we have a dense band-like infiltrate obscuring the interface of the epidermis and dermis. The reedy ridges have a jagged or sawtooth profile, although that can sometimes be difficult to see amidst the dense lichenoid lymphocytic host response. These are the ones that I see most easily. Now, can you see them? Here's higher magnification. Can you still see some pointed reedy ridges? I think it's better on the left side of this image. And centered within or just around the dermal-epidermal junction are these eosinophilic globules that represent the dying keratinocytes. Sometimes the dying keratinocytes are single, sometimes they're clustered, and again, sometimes you'll see the pycnotic nucleus, but it depends on the angle of sectioning. A variety of terms have been used to describe these cells. In lichen planus, at least, the mechanism is understood to be apoptosis or programmed cell death, but keratinocytes that are dying from other causes look morphologically the same. So various terms, cytoid bodies, savate bodies, cytoids, all are referring to the same or similar process that is associated with interface dermatitis, where there's a lymphocyte associated or lymphocyte mediated keratinocyte death. With the cytoid bodies that are only eosinophilic, some of them are a little bit more pale, and those are known to be coated with immunoglobulin. Pycnotic nuclei are highlighted here. And some of these more pale eosinophilic globules that do not have a visible nucleus are more consistent with the cytoid bodies or savate bodies, again coated with immunoglobulin. I hope you've enjoyed this introduction to the dermatopathology of common skin disorders. Over the course of the coming year, we'll be examining each of these topics in greater detail and more.